Hello everyone and welcome to my channel. Today we're going to be reviewing acute kidney injury, AKI. So stay tuned. Now, we always define everything we're going to review. So today we define AKI. Now, acute kidney injury refers to an abrupt decrease in kidney function, resulting usually in the retention of urea and other nitrogenous waste products, and also in the dysregulation of extracellular volume and electrolytes, which basically means there's going to be volume imbalance. Now, there's some criteria we should fulfill in order to diagnose AKI. Creatinine more than 26 millimoles per liter, 48 hours, or 1.5 times from the baseline in a week, and in children, if the urine output is less than 0.5 millimoles per kg hour, 6 to 8 hours. Another criteria we can use for kids is if the eGFR is less than 25% in 7 days. We can also think about stages. Once we've diagnosed AKI, we can classify it according to stages. Stage 1 will be considered when there is a raise of 1.5 times the baseline, or an urine output less than 0.5 millimoles per kg an hour for 6 hours. Or stage 2, 2 times the baseline, or an urine output of less than 0.5 millimoles per kg hour for 12 hours. In stage 3, 3 times the baseline of creatinine and a urine output of less than 0.3 ml kg an hour or 24 hours. During the inpatient experience, the patients will arrive to the A&E with AKI in 1% of the cases. During their stays, 5% will develop and 15% in ITU. Now, the causes can be classified as pre-renal, renal, and post-renal. Pre-renal is usually the most common one, so I would think about that one first. Post-renal second, and third would be renal. Now, discussing pre-renal causes, the first thing that should come to mind is hypoperfusion, loss of volume. Now, there's many reasons why a patient could have hypoperfusion, and as a result, the kidneys will decrease the eGFR to retain sodium and water. Now, the kidneys will be okay at this point, trying to retain sodium and water, but at some point they will go into acute total necrosis because of the lack of volume, basically oxygen and nutrients. Now, pre-renal causes, when you think about hypoperfusion, there are things like diarrhea and vomiting that can cause hypovolemia in a patient. Also shock, decreased cardiac output, like in heart failure. Drugs like NSAIDs, ACE inhibitors, angiotensin receptor blockers as well, and some diuretics, and in some cases the hepatorenal syndrome. Now, post-renal AKI is the second cause, remember, frequency. The first thing that's going to come to mind is obstruction. Now, this obstruction could be intrarenal or extrarenal, so don't always think about extrarenal. Intrarenal, there could be an obstruction at the level of tubules, including collecting ducts. And extrarenal, you can think about calyces to urethral meatus. So anything between point A and point B could be obstructed. The most common causes are going to be stones, a blocked catheter, strictures, especially with patients with background of STIs, prostate problems, and UTIs. Now, the third cause, which is not very common, but you will find it, is a renal cause. Now, there could be tubular interstitial disease like acute tubular necrosis or ATN, which is the commonest intrinsic cause, and is usually ischemic. The acute interstitial nephritis, or AIN, the rapidly progressive glomerulonephritis, which is a glomerulonephritis, and some vasoconstriction causes like renal artery stenosis, malignant hypertension, vasculitis, or microangiopathy. Like HEUS, TTP, DIC, and preeclampsia. Now, we have discussed some of the generalities of AKI. Let's talk about the symptoms. There's some general symptoms like oliguria, and symptoms related to fluid overload, pulmonary edema. Also think about peripheral edema, paroxysmal nocturnal dyspnea, and orthopnea. Other uremic symptoms like fatigue, nausea, and vomiting, and confusion. There are some specific symptoms as well. If you think about perirenal AKI, you might have some postural hypertension, diarrhea, and sometimes vomiting. And because of the hypovolemia, you're going to have an increased heart rate as a response. When you're facing a renal condition or AKI, there will be some symptoms of systemic disease as well. Now, some patients are more at risk of developing AKI. There are some risk factors that you should always remember: organ failure, CKD, liver disease, heart failure, age, hypovolemia, and shock. And a good way to remember nephrotoxic drugs. FANG. So FANG is a good way to remember. FANG stands for furosemide, ACE inhibitors, and ARBs, NSAIDs, and gentamicin. Other risk factors can be diabetes and urinary obstruction. Now, the general approach to a patient with AKI should always start by investigating the reason why the creatinine is going up. Think, is this AKI or CKD? Always think about perirenal or postrenal causes because they're more common, and then think about renal causes. Now, we can order some investigations when we see the patient and we're concerned that this could be AKI. And dipstick is going to give us a lot of information. You might find blood, you might find proteins, and each of them could indicate something. If you find blood, proteins for example, you can think about glomerulonephritis, stones, UTIs, a tumor, or even trauma. Now, if there is white blood cells present, you can think about UTIs or acute intrinsic nephritis. Now, if we send a sample for microscopy, there's a couple things that could indicate a certain disease. Red cell CAS, for example, that will indicate rapid progressive glomerulonephritis. Eosinophils and their CAS and neutrophils will indicate acute intrinsic nephritis. And ATN, you always think about granular tubular epithelial cell CAS. You can also order urinary sodium levels, because sometimes if it's less than 20 millimoles, you're probably thinking about perirenal. The kidney is trying to retain sodium basically to maintain volume. If you order levels myoglobinuria. You could rule out rhabdomyolysis, cultures for sepsis, and immunoelectrophoresis for myeloma. We'll order basic tests to start off, like an FBC. Low HB is always going to indicate CKD because it's usually a chronic condition. Increase of white blood cells is going to indicate infection, and decrease of platelets is going to point in the direction of HUS and TTP. Using these, I would think about potassium going high and what it's the bicarbonate and the calcium doing. LFTs, if they're the range, remember hepatorenal syndrome. Let's get a clotting screen, because this patient could be in the IC because of sepsis. Now usually CKD can also give you altered clotting screens. CK for rhabdomyolysis. You can also request CRP, which will be raised in infection, and AVG to see if there is any presence of metabolic acidosis. Now there's some photobots you could order, like immunomarkers, seminal electrophoresis, and immunoglobulins. Now most of these investigations you won't really be requesting them. You always start with basics: FBCs, USNEs, LFTs. Now at some point you'll want to do some imagings, or even an ECG if potassium is the range. Chest X-ray maybe if you think it's pulmonary edema. Go ultrasound, plus minus, ultrasound KUB, think about X-rays, think about CT abdo. You can also request some biopsies, but that'll be later on. Now, how can we distinguish between AKI and CKD? Well, there's a couple things you can remember. Previous bloods and see the trend. Check the EGFR. If it's improving in the next 24 to 48 hours, it's most likely to be AKI, especially if you don't have previous bloods. An ultrasound will show the size of the kidneys. Small, think about chronic. If there are nocturia or hemoglobin levels, they're usually low in CKD. But you can also have acute and chronic, so never rule that out. Our management is going to be quite simple. You need to treat the underlying cause, the underlying condition. So if you're thinking about pre-renal, remember it's hypoperfusion, so fluids and most of the times antibiotics if you're thinking infection. If it's renal, then stop all the medications that could be causing it. Or you could do some immunosuppression if you're thinking about rapid progressive glomerulonephritis. Postrenal obstruction, then catheterize. We should always keep a strict fluid balance to know what's the input and output of fluids. This will help us prevent hypovolemia or overloading the patient. Now if you're not too sure about the cause, remember you can always get support from the renal team. They will always be happy to help. Now there are some complications you should keep in mind, especially metabolic acidosis, hyperkalemia, and pulmonary edema. This could all be life-threatening conditions, and the patient could have a poor prognosis, especially if they're above 50 years old, the AKI develops in the hospital, the urea is rising, oliguria for more than 2 weeks, or there is another organ that's failing. If the AKI is severe, you could think about renal replacement therapy. Remember, the renal team will be involved at this point. And there is a phase that you should always keep in mind, the polyuric phase. The reason why I bring this up is because you might feel reassured when you see the patient that it's producing urine, but remember, the tubules are regenerating, recovering, so they're not really doing any retention or any reabsorption, so they're just passing the fluid without properly filtrating it. So I would think about that. to fluid balance is very important. So that's it for now. Hope you enjoyed, and I'll see you again in another lecture with Dr. Luke.